Just one quick note before we begin talking about diagnosis and assessment. The book begins with a review of reliability and validity, and those are crucial topics, but I'm not going to cover them here nor test you on them. That's not because they're not relevant, but rather because we're already covering a lot of information. Suffice it to say, however, that your conclusions, in this case your diagnoses, are only as good as the data you collect. So the reliability and validity of your measurements play a crucial role in client conceptualization. Now we're going to do things in what may seem like the reverse order and talk about assessment. Overall, the purpose of assessment is to gather information about a client's past and immediate context, his or her current functioning, and his or her future goals to determine and plan best treatment. Now, there are a multitude of different assessment methods, ranging from interviews to observations to tests, all of which can give you crucial information about a client. The method that you use should be based primarily on the questions you're trying to answer. However, the reality is that available resources also play a role as well, which is why clinicians are most likely to use interviews. So let's start by talking about those interviews. We can think of interviews as falling into one of two categories, unstructured and structured. Unstructured interviews, which are also known as non-directive interviews, are those in which questions are not prearranged. Rather, the questions occur organically based on the interaction between the parties involved. In the context of treatment, that means between a client and a therapist. These unstructured interviews are often one of the first things that practitioners do with clients. And with most forms of data collection, there are both benefits and drawbacks to unstructured interviews. In terms of the benefits, unstructured interviews can be particularly helpful in developing rapport because the conversation can occur organically. In addition, unstructured interviews remain very focused on how the client sees his or her life experiences, which may be missed if the questions are prearranged. However, sometimes it's difficult to cover all relevant information because the emphasis is on letting the conversation occur more naturally, and because therapists are so focused on clients' perspectives, that's the only perspective that you typically gain from an unstructured interview. On the flip side of that are structured clinical interviews, which, as you might expect, are comprised of prearranged questions that the interview will just go through one by one. There are a lot of different structured interviews out there, depending upon the information you're trying to collect. However, when it comes to gathering basic background information, as well as information pertaining to symptoms, probably the most popular is the structured clinical interview for DSM disorders. In this interview, practitioners basically talk through symptom lists to gather information about a range of symptoms the client might be experiencing. As you might imagine, some of the benefits of structured interviews are simply the opposite of unstructured interviews. So whereas unstructured interviews can struggle to cover all of the relevant information, structured interviews provide a standardized approach to gathering background information, which can be helpful so clinicians don't miss any important topics. Structured interviews can also still allow for rapport building if they're done well. However, structured interviews often take a lot of time because there are a lot of topics that have to be covered, and in addition to that, structured interviews don't allow clinicians to make clinical judgments about which questions to ask and not to ask. The next method of assessment that clinicians rely on for the purposes of diagnosis is observations, and that includes any circumstances in which clinicians are directly observing the behavior of clients. So, for example, let's say that I was working with a kid whose parents were concerned about aggressive behavior. Sure, I would meet with the kid and the parents in the office and spend some time in that setting, but I would also want to see what the kid is like in different settings as well. So I might do some school observations where I sit unobtrusively in the back of the kid's classroom to see how they behave during the school day. I might also do some home observations to try and get a feel for how the home setting might be contributing to the reporting behavior. And by doing so, I can start developing a more complete picture of who the child is. The benefits of observation are pretty straightforward. By design, they often provide clinicians with the opportunity to see a client in a more natural environment than just the office. Also, because I'm actually observing a client's behavior rather than just going off of what the client or the client's friends or family members have said, I'm eliminating some of that potential bias. However, I'm also introducing some other bias, that being my own. So one of the drawbacks of observations is that they presume a level of objectivity on the part of the clinician that may not be completely realistic. Also, because they're extremely time-consuming and also expensive, clinicians typically only do this once or maybe just a couple of times. So it's not certain that the behavior the clinician observes in those few observations is actually representative of the client's behavior all of the time.